I am your presenting surgeon, and as Dr. Agazzi said, I am faculty at University of South Florida and working in Lehigh Valley. Our first discussant is going to be Professor L. Madison Michael. We're going to talk about what that L stands for in a little bit too, maybe. And he's going to be one of our two discussants to give a counterpoint to maybe critique what I did and critique what Gabo was talking about and so on. But I decided that since you all were so many of us here, that we should have a counterpoint. And so Dr. Zada has graciously accepted that role, and so we can get a four-way back and forth this time round rather than just a three-way. And so now finally introduce the hot seater. As you can see, fellow to Siviero the first of his name, king of the Andals, protector of the realm, lord of the seven kingdoms, and the NASBS. You didn't know that you were in Game of Thrones, did you? So again, so that's off we go. So if you've seen previous episodes of Surgeon's Law, you know that every episode has this weird title. This title is called Open Sky Gull Wing. Hopefully there's no plastic surgeons in the audience, so give it away. Okay, off we go. Your victim, oh, you have to see, okay. Your victim is an 82-year-old man with a chief complaint of confusion and sleeps a lot, per the wife. Actually, the wife says that he's been very nice to me lately, which is very unusual, apparently, for him. He has no interest in his surrounding people activities, and the symptoms have been progressive for the last couple of months. The only relevant history is that he's got a little bit of AFib and hypertension. So pretty healthy 82-year-old, especially coming out of eastern Pennsylvania. Neurologically, he's kind of unremarkable, really. He seems to be just a little bit disengaged, but otherwise everything checks out just fine on the exam. So what what do you think we're looking at in terms of localization?
Well, first of all, changes on behavior is one key in the question. The other question is disinterest in activities, which again go to behavior. In an 82-year-old that changed in the past is progressively, as you mentioned, with no focal deficit perceivably, at least no visual complaints, neither.
Nope.
And other than that, any headaches?
Not really complaining about a whole heck of a lot, really.
Well, most likely it could be pointing more some pathology in the anterior cranial fossa, frontal lobe.
Okay.
It could be maybe temporal lobe.
So you know, we're doing this for a much broader audience, right? Because we're taping this and recording. So you know, we always talk about localization first when anything neurological, and then we start thinking about tests and interventions and so on and so forth. So does anybody disagree with the frontal lobe interest?
How is the smell?
How's the smell? Unknown. He's not complaining about it. You ask him and he's just kind of like, no, I don't know.
Can we test it?
Well, not in this initial encounter.
We can test to the same line, Dr. Senonos. If he was to a clinic, I don't know, see optic, there's any type of papilledema or something particular.
Right. So there's hard to appreciate papilledema in the office, but the most remarkable thing is he's just kind of, you know, disengaged, like uninterested.
Yeah, I think based on the fact behavioral problems, disinterest made me think mostly it's a frontal lobe pathology, and that's my call.
Very usual thing that we do. What do you want to do? What?
Let's start with simple. If you haven't done anything, we can start with the head CT.
All right, I got better for you.
Okay.
All right, so tell the audience what you see and what your eyes are drawn to.
So back to the basis, they're like, first of all, it's a T1 post-contrast study. There's three versions or three cuts. It's a coronal, axial, and sagittal, and that. Sorry. Yes, so it's a T1 post-contrast MRI. They're like coronal, axial, and sagittal cut. It seems to be, or pointing to be extraaxial tumor with apparent maybe some perilesionar swelling located probably mostly no close to the planum, cruciform plate, probably olfactory groove meningioma.
So, obviously you're very senior in your training. So for the younger audience who's watching this, later on,
Yeah.
what you see here would then draw your eyes into what other piece of information on this study that's not particularly shown here yet.
Because not sure, maybe just to look at the sinuses. That's what you're asking for.
Well, I'm not asking. I'm asking you. I'm not, it's not like guess what I'm
Based on the
thinking. So sinuses. Okay.
sinuses, yeah. But I think that this information I have from this scan is pointing location and age and how it looks and characteristic. I think it's just probably olfactory groove meningioma with some planum extension.
But it might affect your intervention. There's one thing you said about this scan. This is becoming what gets what I'm thinking. There's an aspect of, especially the one on the left-hand most side, that's going to draw your attention to a particular sequence of this MRI. That's going to affect your intervention.
Well, yes. Well, there's sequence. You can do, first of all, you should see the T2, at least the appearance of the perilesionar swelling.
All right. So
Because
tell me how, again, tell me what you're paying attention to in this particular picture.
So in T2, I'm most paying attention. Sorry, I didn't ask the question. Is that right hand or left hand dominant?
He's right-handed.
Well, mostly right hand dominant persons or human beings tend to be, with a left frontal lobe dominant in the sense of behavioral problems and potential injuries. So it will determine what approach you would choose. In that sense, in an 82-year-old with AFib, you have to take consideration if he's in anticoagulation or any type of medication. So you have to think very strategically what is the goal of surgery, taking that in
Well, so
consideration.
we're not quite there yet.
Okay.
Does it jump out at you as a little bit weird how the whiteness is?
Well, it maybe jumped out because it's just restricting to the white matter. It jumped out probably because it's just the whole frontal lobe is swell.
But I would point out that it is interestingly unilateral.
Yeah, correct.
And that actually can play a big part in some decisions later on.
Yeah.
So just to point out that there are some nuances that you may want to pay attention to. So, okay, now let's move forward. So what is it and what do you want to do about it?
Well, there's always options to give to the family and patient. We should discuss, first of all,
So you already said what it is, so let's reiterate.
I think it's a meningioma,
Okay.
olfactory groove. It looks like a meningioma.
Okay?
It smells like a meningioma.
Okay.
And it's just with a very dominant swelling in the left frontal lobe.
So do you, what's next? Do you want to intervene, in some ways right away? Do you want to get more testing?
I think that it's easy to look for grossly indications to justify a surgery, but I think the first step is talk to the family and see what is the sense of they're keen into, because there's always three options regardless of what the MRI shows. Doesn't matter what I recommend.
Pull it
but
back 1 second.
Okay.
Pull it back 1 second. Let's think about more basic stuff. You can do something real quick in the office to help him a little bit right away.
You can test KPS, see how we, mental minimum examination.
Ken is trying to give you the hint.
You can do, I don't know.
He knows. He's reading my mind
Huh?
because, yeah.
Well, yes, of course, steroids, medical, yeah. I was going that way.
A lot of times you assume that they're already on steroids and whatnot, but
Yeah,
you
sure.
should always think, oh, well, let's see, maybe not. Again, you are coming from very big programs and very good training programs, but you never know when the next practice is, and maybe some family practice guy sends it to you that didn't think about that. So, you want, yeah, that would help out a lot, I think.
Almost a lot.
So any more testing that you want?
Well, yes, I agree with the steroids. It should be started right away because of the potential swelling. I think I will do a formal ophthalmologic evaluation to
Okay.
look for papilledema if it was not done,
Okay,
or atrophy,
Okay.
something that go with Foster-Kennedy syndrome if necessary.
okay,
We'll do a complete CT scan just to see the sinuses.
okay.
You can
You
consider.
just use a big word. Let's again explain to the PGY2s who are watching Foster Kennedy.
Foster-Kennedy syndrome is a constellation of contralateral, ipsilateral papilledema and nerve atrophy with some behavioral changes. That's what's constelled or discussed affects Foster-Kennedy syndrome.
And Dr. Zanonos is over there asking for his test that he asked for 10 minutes ago.
And the smell one too.
Okay. So all those are very reasonable things to do. I don't remember whether we sent him to ophthalmological testing. His AFib was handleable. I think he was already on some minor anticoagulation that can come off. But really, the question is, what are we going to do about this, though? He's wait a minute,
82.
82. Shows you this picture. Not the sickest 82, but not the healthiest 82. We've done this already. Yeah, I mean, is there any treatment?
Well, first of all, again, we have to step back. We haven't said about the cardiovascular evaluation. Make sure it's fitted for, if we consider surgery, what is, if any, fitted for any type of surgery.
Okay.
Is fitted for surgery.
So wife says that he's, been he's been very active all along. Again, she's enjoying the fact that he's actually being nicer to her than usual. That's cranky and curmudgeon-y. And she sees no particular reason to just kind of, throw in the towel with a little bit of AFib.
Okay. And then after I go then explaining that, all the features point at the indication is surgery. Are they keen to go to surgery?
Well, we haven't gone. So treat or not treat?
Well, yes, I think that.
Yes, treat. Okay.
Yes, treat.
So then comes the question of what treat. So they're listed. What do you suggest?
Well, of treatment or well, this either you can consider first choice will be surgery. Second choice should be given observation, right? You're true. It's a also part of surgical management, right? Saying no surgery based on them, but we favor surgery. Also, you can consider radio surgery, although the volume is too high, but it should be considered option to them, but not highly recommended. And once you establish this relationship with the family and they are keen to surgery, that you already tell them that you favor it, then you can go to the surgical option or
Okay. So they're. I don't think they're interested in just kind of waiting it out and just where the steroid goes and all that.
okay.
Is there a role for just biopsying this thing and doing something more conservative?
Well, again, it smells like a meningioma. It's probably some meningioma. You can consider, you can have in your back of the head a mind of biopsy it, but again, I don't think it would change that much in terms of if you do surgery, there's already mass effect, there's swelling. I think the goal should be resection.
No. So before we talk, is there anybody in the audience who thinks that this may not be a meningioma, that maybe biopsy and something could be a reasonable thing to do? No. Oh, hey, but we got a little bit.
Small possibility.
Small possibility. But not very thrilled with the idea, no?
Let's hope about it, but it's easier to less open.
All right. So families like, okay, whatever you think is appropriate, doctor. Okay, we're trusting you. So now, you think surgical resection?
Yes, sir.
Okay, now the drum roll starts, right? First we start with the $5 question, then the $10 question, and now it's $10,000 question, and now the $1 million question at some point. All right. Without saying your chosen one yet, what are the options? Just lay them all out on the table.
Well, options, and they're controversial by nature because of the location of the tumor. option could be endoscopic based on the midline location, not extending beyond the optic nerve, and then two,
Endoscopic, I'm assuming endonasal.
endonasal, yes, sir.
Okay, number one. Okay, two.
And cranial approaches, you can even choose, depending of the pneumatization of the frontal sinus, supraorbital craniotomy, temporopterional, bifront.
Slow down. One.
Sorry,
Okay, number two, okay, so transcranial is a big group.
tricranial, yes, sir.
Okay, number two is one of the transcranial, okay, let's lay out one. You said
So I think the standard workhorse of every neurosurgeon is pterional.
pterional, so unilateral pterional, which side?
I think that based on the fact that it's midline and it's not favoring either side in terms of location, I think I would choose the right side.
Right side, okay, so pterional is number two. Number three,
I think you can also consider, if I have a CT scan, a supraorbital craniotomy, and try to consider to see if we can reach and take out the tumor
so
too.
supraorbital, so LSO, sort of the top half of the pterional.
Correct.
Okay, number four,
Number four,
is there number four?
well, you can choose a traditional bicoronal, which is a little bit more extensive, more midline, and try to, get to the frontal side of the tumor and just tackle there from that
It's
side.
interesting, and again, sidebar, editorial, that bifrontal bicoronal is now traditional, which is kind of almost has an icky connotation. That's like, but I bet you that a huge number of neurosurgeons would say, obviously bifrontal bicoronal. What are you talking? Of course, bifrontal bicoronal. Now, if
If you're
you
gonna be old school, you could say subcranial, could take out its orbital band.
so subcranial, which is kind of like what Antonio Aversa is advocating and whatnot. But okay, let's say we do bicoronal, bifrontal. There are still variations within that. So would that option be subfrontal or interhemispheric or both?
Hard to say. I have to have a CT scan to see the sinuses to figure out.
Let me peek whether we have a CT scan.
Because it's hard. You can say blindly, yes, it could be an option, but you're now putting a patient on a more morbid surgery in terms of saturation or exposing the sinuses, or
So you want to avoid the frontal sinus if you're going to do it bicoronal?
Well, I think so. I think so. If we're talking about 82-year-old gentleman, that I think that they already started Chagall's surgery.
Okay.
And I think so, but again, I have to have a CT
So
scan.
now really the million-dollar question, now that you laid out I think 5 options for all of us, your personal favorite option for this guy?
Oh, geez. By the way, disclaimer, I'm a novice. I'm starting in this scope base.
No.
But-
You got PGY8, in what planet are you a novice? No.
Well, because-
You don't get to play that.
No.
You're out in practice. Your fellowship director just signed the form for you. Tomorrow, you're wherever you want to go. Your shingle is ready to go. You got this patient right at your office. Which way are you going to go? And why? Now you could go through all 5 of them and say pros and cons, pros and cons, and then decide.
Well, in my mind, I think I might choose to have maybe 2 options. I think either you can choose the endoscopic route, although again it's controversial because the closeness of the frontal sinus and limitation of it, or I would choose maybe arterional going from the right approach. I think that's my favorite choices at this point.
Okay.
And the only thing I would not say the supraorbital is because maybe the bulk of the tumor is too much to get to that plane of brain relaxation that I need to achieve what I want to achieve with this case.
And given that you're in practice with a shingle up and whatnot, there is no controversy because what you decide is what you decide. When they sign the consent form, they don't say with contingency that this is controversial. They're going to say, my doctor said this is the way, so that's my consent. So okay. Now you said endonasal endoscopic, and terional,
Yeah.
okay?
Can you don't mind putting the coronal again and the side also imaging, please? Can I stand up briefly?
You can do, you can go up over there and take a closer look. Now, when you speak though, you have to speak in the mic, because we want to get it recorded, on the record.
A round of applause for Rambo.
There is no wrong answer, as long as you can, get the consent.
I think based on the fact that he's 82,
Mm-hmm.
and I think if I took the mass enough, I think I would consider arterional in this case. And the only rationale being is that I know that although I know it's 82, it does carry some percentage of morbidity, mortality, also morbidity of doing endoscopic approach. There's still some limitation that might be regard to how close is all close to the crista galli in that point to the anterior frontal sinus, or it can be done.
So
But I
by
think-
the way, this goes back a little bit. You said something very important, which I skipped a slide actually. You said as long as you get enough of this, are you intended to leave something behind, or are you?
No.
What is the actual goal of treatment here?
I think the resection of the mass, but if you go by the fact that you're gonna leave if you go cranial, you're gonna leave, of course, the bony element or dura or bipolar. It's not a symptom grade, and it's our classification, but it's not a symptom grade 1.
I would argue that the primary goal of treatment is decompression.
Correct.
And so if you left something behind, is not a big deal, especially in the 82.
Correct. So that's
So in fact, if you design a way to just decompress the brain with intended partial resection, I don't think anybody can really fault you for this.
No.
So, but is that your goal?
yes. My goal is to attempt safe resection. If I can do a safe resection and take the tumor I can with the approach I'm gonna choose, yes, a safe resection. That's why I think I would choose arterional. I would not choose in this case based on the fact that age and comorbidity. I think I would choose.
So
a
you're
arterial.
happy decompressing and get out of Dodge. If you leave something behind, so be it. So a right-sided terional.
Yes, sir.
How big of a terional? What do you mean by terional?
Well, I think-
terional or
More-
mini terional or mi plata or
I think more frontemporal craniotomy favoring, of course, the frontal bone enough that I can have approach to the optiocardiac cistern or subfrontal cistern to release CSF and get the approach done.
Okay. Outstanding. Great choice. You're done. Good job. So now, before we move forward, anybody want to chime in here and simply react to what Gabo said or has said?
You ended up testing his olfaction.
You, no, we didn't end up testing olfaction, George.
Just ask.
Ken,
I think you did a great job on the hot seat, so I'm glad it wasn't me. And
you'll be next.
I'm leaving. But
There's Atlanta.
I think that that's a good option. The other thing that I would maybe consider is potentially if you're just trying to decompress him and he's 82 years old, a healthy 82, but still 82, you're going to put him on steroids for some time being. What's the least amount of cutting and drilling and opening that you can do in order to achieve that goal of the surgery? And in my opinion, and full disclosure, I came from the school of Walter Jean, so please forgive me if I don't agree with what you were going to do. But, I would be thinking something more, what's the least invasive thing that we could do to get the tumor decompressed and debulked? And in my opinion, that maybe something like a supraorbital craniotomy, something sort of eyebrow incision, that's going to allow you to at least access the tumor, debulk it from a small opening. And in my opinion, I would even consider going on potentially the left side, because what I don't want to do is retract the right frontal lobe a significant amount and then God forbid you still leave some tumor, there's still swelling. Now he's got bifrontal edema, but that's maybe up for debate. But the point I guess I'm trying to make is what's the least
That's
cutting
always
we
the
can do?
double-edged sword, and that's a good point to bring up. We say, oh my God, there's a horrendously angry hemisphere. Let's go the other way, and then you end up mucking up that hemisphere, and now you got really up, the creek. So that always is a danger, especially when you're doing occipital stuff. In my practice, your second choice was EEA, right?
No, I think it was there. I'm gonna be honest. Like I was thinking, that's why I take a look and thinking about the whole like idea of what is the goal of treatment. I think that again, endoscopic is sexy in a sense of terms of approach and I think, but it should be choose to the right patient and right indication too. And it's a good
Does
tool.
anybody in the audience either think that endoscopic endonasal either is a slam dunk must do or is not possible for this?
Walter, I wouldn't say not possible, not advisable.
Not advisable.
For what reason?
Dr. Zimmer, please tell us why you think that.
82, you're making a huge defect in the skull base with the goal of decompression and trying to get as much out as you can, at least in this measure possible. So I don't recommend going in and tearing up this entire skull base to reconstruct this thing. When you can go through a much more minimal approach without.
We'll table that for a second because we want you, Mike, to re-explain. So I jumped the gun. We will go to the at the end. We will go at the end to Phil Donahue you all about this. Okay. All right. So my turn. All right. So I am going to go towards my. So we went through this. We said these are kind of the arrows, and you ended up picking the blue arrow essentially, and that was your approach to short. Okay, let's move on. So I am your presenter, the moderator, presenter, judge, jury, executioner, all rolled in one. I am, that's who I am. So the problem is this is not that patient, obviously. This is one of my PTSDs from my career, and something like this kind of lives with you. This was, and it wasn't my case. I happened to be on call to finish the job. This happened to a patient that had the subfrontal approach to this tuberculum tumor, not my choice and not my patient. The frontal bar, the bandeau was taken off, front bifrontal, and there was a handheld retractor for a little bit, at least, taking this tumor out. And this was the CT scan is post-op day 3 or so when the patient was no longer responsive. And then, I was the unfortunate person to take this person to surgery, and we could not close the skin. Needless to say, this didn't end very well, and it stuck with me for a long time. So this bifrontal edema thing is something that I'm always very scared of. What about the transcranial approach? And then you didn't choose this, but the quote traditional approach, with the bicoronal incision, it generates sometimes this thing, which is very aesthetically not pleasing. This is a real patient, and it's, this person sat on my service for a while, looking like that for not a short time. I personally have been very influenced by this particular paper that the Schwartz group put out from Cornell, and I don't know the audience thought about this. This came out with the anniversary edition of JNS, and that he said that basically planum's no go, tuberculum for sure, planum no go, tuberculum for sure, and it has to do with the resection rate, and that transcranial often have higher resection rate for and lesser complications for olfactory grooves, flipped for tuberculum sub. So I did happen to talk to Ted quite a bit about this paper and whatnot. So I'm personally not a big fan of doing EAs for OGMs. Now, tradition, again, that word. This approach is old. This transfrontal sinus, using the frontal sinus thing, you know where this left-sided panel comes from John James Sr. It actually comes from one of my favorite books that I have very prominently in my office, which is the personal perspective book of the, it's called Neurosurgical Procedures, a personal guide to personal view on the procedures. And he writes about using the frontal sinus to access these things. And lo and behold, Haydong Zhou did the same thing, and this French group did the same thing. And, you know, Mike Chacoin and I have been thinking about this and going back and forth about this and starting to using this and at least thinking about using this, right? So, with you trying to avoid the frontal sinus, we're actually going to use the frontal sinus. So then comes this bicoronal thing now. How to get around the bicoronal thing? I happen to find a interested plastic surgeon who likes using and does not mind using this incision called open side gull wing, which is this. So here you go. This is an open side gull wing incision in an 82-year-old with a lot of creases. It kind of looks like a Batman thing. And so we harvest the pericranium, and you know we use the pericranium eventually, and then we simply use the frontal sinus to our advantage. So we mapped out the frontal sinus with our fancy tools, and you can use navigation, you can do all kinds of. That's your minimally invasive keyhole opening. We take out the mucosa, we drill it out with we drill out the frontal sinus with, so we cut the superior side of the sinus. And, you know, there's tumors right there. And it really, and then we put the endoscope in there to look at the base, and then take out that little tiny piece, you know, kind of coagulate the base. And then, as Antonio Aversa, you know, teaches me, at least to close the dura real as tight as possible so that there's no leak. And then you, of course, all use the kitchen sink to kind of close it. And they do a plastic closure, and then cosmetically, it's their, you know, game to play then. So this guy then ended up with this. This was only a week after surgery. He looks like someone beat him up, but it healed quite well at the end of the day, and his abulia improved, and he did not have a leak, thank God. So we call this the open sky gull wing incision transfrontal sinus approach, and we've done about 6 or 7 of these in people, in patients that ask specifically, what do you think about a bicoronal incision? What do you think about eyebrow incision? Is this, you know, disfiguring or not? And the patients play a big role in what to choose. So, moving on, our guests, please take your positions.
How long was your
Doc,
surgery?
Dr. Madison Michael is, of course, a board member, and he is from the proud state of Tennessee. And Dr. Zada is from the opposite coast, and I have the Fighting Trojans here as well. So I am going to shut my computer down now and listen to y'all talk, and then maybe we have some rebuttal at the end. And then, of course, Phil Donahue starts.
I think
Would you wants to start?
well, we were talking about we really want Jerry Springer, okay?
Oh,
Not Donahue.
We want some
Yeah.
some things thrown around, and there's a reason that nobody had oranges or bananas for dessert, because I do not want anything thrown at me from the Lee Zimmer world over there. So, so whenever you have any skull base pathology, to me, there's two kind of things that you have to wrestle with. One is, what's the goal of surgery? So you got an 82-year-old that's got a skull base pathology centered on the olfactory groove, lots of edema. I really don't know what else it could be than a low-grade meningioma. So I'm dealing with a low-grade pathology. And then I also think about trajectory. So I would say 30 years ago, a lot of people thought about skull base approaches from the 270 kind of approach where you wanted to kind of see 3/4 of the way around the lesion, and that was the approach that you had. I think most of us have moved to more trajectory-driven approaches, so I want to kind of find the right trajectory that I'm in line with the tumor that's done all of the dissection for you, cavitate it, move it into your field, and then remove it. So looking at this, there's essentially an anterior approach, an anterior lateral, or a lateral approach that you could use in addition to an endoscopic endonasal. So I'm going to assume that this 82-year-old can't smell, because I do think smell is a big deal in trying to approach this. But if the person cannot smell, I don't know how you could not choose an endonasal approach. You basically have a tumor in which the first thing you want to do is devascularize. So I can get to the anterior and posterior ethmoidals right off the bat, devascularize the tumor. The growth pattern of that tumor is strictly from the olfactory groove. There's no tethering over the orbits. Everything's kind of tucked in tight to the olfactory groove. I know I don't have to get it all out. I don't have to get a Simpson grade 1, but I bet I can make that MRI look perfect. So coming from below, I think that we could remove it. I fully believe that you can close these. So I want to go back to that Ted Schwartz paper. Ted is a master surgeon. There's no doubt about it. But answer me this. Why can I close every single other location, but not that one? I mean, why do I have this kind of off limits? I can do tuberculum, I can do planum, I can do the clivus, up, down, all around. I can go lateral out to the infratemporal fossa, but I can't do the anterior fossa. It doesn't make sense to me. I think that when you look at the evolution, number one, that paper didn't show you the number of patients that were in it. It was an invited article. So you don't have the number of patients that he treated. You don't have his indications. I mean, the reality of it is on tuberculum, cellum, and planum, they typically are forced to be symptomatic at a much smaller size. But the anterior fossa meningiomas, I mean, it's lucky that this guy had this much edema, but most of them come to your clinic, basically clicking their heels, no problems at all, no edema at that size.
So Dr. Michael, Professor Michael, what about that anterior tip of this tumor? That is a very steep turn from the endonasal. Is that an intended residual that you're okay with leaving, or do you think you can get it?
I totally get it.
You can totally get it.
Yeah, I mean, he doesn't have a frontal sinus for one. So you've got that in your favor. We do that for aesthesios all the time. I mean, there shouldn't be a problem getting that. So our closure technique is remove it. It's just like subtemporal, subfrontal. The brain coming down at you is your friend. So remove the tumor. We do an inlay graft, a single inlay graft, quite redundant, and then a nasoseptal flap. I mean, again, that Ted is, like I said, you can't get a better surgeon than a person like this, but he doesn't go into how he closes that. So you don't really have kind of a basis. And maybe he had those two periods, two different closure techniques, or maybe he kept it the same.
Let's keep the questions until then, so I can get to you with a microphone. Professor Zada, go.
All right. Great case. Gabriel, great job, first of all. Nice work. Gabriel.
Gabe.
Strong work. This for me, I mean, you have an 82-year-old altered mental status, edema in the dominant lobe. He has AFib. You have to think about the AFib, right? You have to make sure that he's a candidate for surgery, assuming he is. He's not on anticoagulants, etc. All day long, this is a supraorbital case for me. With second being a terional, EEA much lower on the list. And I love what you did, first of all. I love your approach. I have never done one of those, but I really like the idea of it. So why a right supraorbital for me? First of all, the number one parameter for me on a case like this is OR time. I want to keep this guy under anesthesia for as little as possible with AFib, age, and an extended EEA in this case, minimum is a 4-hour case. I don't care where you are. Probably 5 to 6 hours. A supraorbital, maybe 2 hours, maybe 3 hours tops. Eyebrow incision heals well, 82-year-old, not a big deal. You're going along the long axis of the tumor on the non-edematous side, coming under the gyrus rectus, and you can leave tumor in the fovea ethmoidalis, which is often challenging with the supraorbital to get down to that area. But in this case, it doesn't matter. You can leave a little residual way down in the ethmoid region, and it's not a big deal. If it's a grade 2, he might need some radiation. It's probably not, but it could be. So for me, that's the best approach. The funnel sinus is really minimal on the right. It's non-existent on the left. You can come right above or lateral to that funnel sinus and navigate it. Even if you get into it, it's so small, you can reconstruct it very easily. You could pack it off. So for me, it's a supraorbital all day.
So this is interesting. Now,
No,
now
I never
obviously-
take the rim on a supraorbital. I do them all.
Obviously, they had the chance to look at the case, and
Yeah.
they prepped their comments, and Gabo was the only one who didn't know the case. So I of course know what they were going to say, and I prepped the comments to rebut them. So I have a couple of things.
Wait, can I ask a quick question real quick?
Yeah.
For you, lumbar drain or no lumbar drain?
None.
Okay, got it.
First of all, it's interesting that I thought that the person who would choose the EA was the other person, and the person who chose the lateral was the other person. So you there goes to show you never know what
Curious.
you all think all the time, even though we know each other pretty well. So here's my rebuttal.
Rebuttal to the rebuttal. Of the
I tested out the LSO on the VR, and actually it worked really well. And in retrospect, I kind of thought that there was going to be a longer reach and whatnot, but I tested this out in the machine, and you can see the entire thing, and it happens to be right down an axis of the tumor. I think at the end of the day, I think it was a longer operation, and I'll explain why. But I think it would have worked equally well. With regard to the EA, this is Professor Marcos' slide. I borrowed from him liberally. And he, of course, is dogmatic about not doing anterior fossa meningiomas from below. He calls it the earthly terrestrial versus the heavenly celestial view to these tumors. And he always, because he is so heavenly, he always tries to choose to go from above. But my point for this OGM is this. So again, using the VR, look at the trajectory to the pituitary, which is the green. To get to the front of this tumor, it's almost an entire 90 degrees. And I looked at that and almost, I pointed out to you right there, it's almost a 90-degree turn. So that's what makes it impossible in my hands to do this EA.
But do you have the 90-degree drill?
You need it. The 30-degree scope gets you right up to the
Yeah.
back of the funnel sinus,
Yeah.
like you said, for aesthesios.
So, but I look at that, and for me,
You're
it's
gonna
a
do it.
very intimidating turn that I would not do.
Your point
Now,
of time is spot
I'm supposed to take this mic,
Onward, onward.
and Dr. Zimmer, I'm coming right for you.
Would take some-
This is going to take Roberto's some
Me too.
camera skill, I think. So, I believe Dr. Zimmer had a comment about to respond to Dr.
Make
Mike.
sure he doesn't have anything in his hands.
So
Just coffee. So when I looked at this case with the patient's age, his comorbidities, and the approaches, to me, transorbital was screaming for this, for decompression, subtotal resection, and hopefully taking care of his intracerebral issues. Trust me, I love doing the transnasal approaches, but that's a very large. Let me back up to Walter's concerns. I don't think you'd have any concern getting to the front of this tumor, up in the frontals. And I use 45-degree scopes on all my approaches to the anterior cranial fossa. So that to me is not an issue. My issue is that our reconstructive ability doesn't have a 0% leak rate. And this guy's 82 with comorbidities, and if he does leak, we're going to have a lot of problems. And our goal isn't full resection on him at his age. So I think a brow approach, which I saw a lot when I was at the University of Cincinnati, just for these type of tumors, has an excellent result. It's low OR time, good cosmetic result. And quite honestly, I'm of the feeling, and I've seen enough of these, that a small rent in the frontal sinus, it doesn't even really need to be reconstructed, quite honestly. And the Gull wing approach, I'm not even sure you need to strip out the mucosa and pack that off. I think as long as your frontal recesses aren't touched in the approach, you can just do a posterior wall reconstruction, anterior wall reconstruction, and let it heal in, and it'll be fine. We're learning that through trauma. We're getting more minimal on frontal sinus trauma. So, if the frontal recess isn't touched, I think the gull wing in a crease 82-year-old is not a bad idea, because the way you reconstructed you did fat packing in the frontal recess, stripped out the mucosa, or frontal sinuses, stripped out the mucosa,
Yeah,
right?
yeah.
He's not going to live old enough for his mucocele, which is going to happen.
So there was another question I want to respond to. There was a question to me about how long my operation lasted. So the gull wing incision takes my plastic surgeon about 10 minutes. The craniotomy in this takes about 10 minutes because it's such a small thing. Getting to the tumor takes another 10 minutes. So almost 30 minutes into the case, you're at the tumor, taking the tumor. Now, the longest part actually is the closure. So to close this thing properly, it actually takes longer to do that part than the tumor resection. So it's kind of like backwards to what we traditionally think of as neurosurgery. We need the long approaches, get in there, skull-based surgery, and long approaches, get long resection, and then closure. Just throw a bunch of, whatever in there as long as it doesn't leak. But closure actually takes longer than the actual action.
And that's the biggest criticism of my approach, no doubt about it. I do not agree with the high CSF. You got to understand, even transcranial approaches for this have a leak rate. So our leak rate is quite acceptable for this pathology, but I will give you the time. I will give you it. It would take 4 to 6 hours to take that out.
And my response is the orbital approach has a much lower leak rate than any EEA approach. And in this gentleman at his age, I would take that in consideration. It is low, but it's going to be lower from a orbital or gull wing approach than it is from our EEA approach. And I'm a very fast exposure surgeon and raising flaps and everything, but you're still talking at least an hour of work to get all of that exposed up to the skull base. Then you got to drill it out. It adds a lot of time, and I think even in the best of hands, and maybe if Danny's here, he could comment in Columbus, but that's a time-consuming approach in getting prepared for the reconstruction.
So we continue with this backwards thing where a otolaryngologist is advocating a transcranial approach and the neurosurgeon is advocating a transnasal approach. So please.
In that wine.
Do you have any radiation
Here's-
oncologists here?
Here's the ENT who's going to talk about the endonasal approach. First of all, for the trainees, the best approach is what works the best in your hands. I don't think there's a right or wrong approach. All those are important considerations. If the dura on the posterior table of the frontal sinus was involved with meningioma and you ended up with a dural hole that you couldn't close, it would have been an issue for your approach. So no matter what approach you do, there's that last cut where you may leave tumor. If you're coming from below, you may leave tumor along the falx. If you're coming from above, you may leave tumor on the skull base. As an ENT, I deal with the consequences of the neurosurgeon's decision. If they say endonasal, I have to repair it, and if they say transcranial, I don't have to worry about it. But if Dr. Michael called me to repair the defect, in a case like this, in an 82 years old, I would actually do abdominal fat and nasal septal flap, because oftentimes, the brain is not large to fill the dead space. And in our experience, alloderm and nasal septal flap is not as good, or any free graft with nasal septal flap is not as good as abdominal fat and nasal septal flap. So, yes, you can reach the posterior table of the frontal sinus, but beware if you have a dural tail enhancing up, then you start reaching the limit of what you can do, just like you should watch over the orbital roofs. But from a reconstructive perspective, this could be reconstructed endonasally with acceptable risks.
George, go.
Thank you. It was actually a really great case for discussion. Just a couple of comments. One is for an endonasal approach, you don't actually need to get a CSF leak on this. You can do an approach where you kind of really just debulk the tumor and then just stay within the tumor. And then that happened when my partner Paul actually tried to do a staged approach in a couple of cases, and they just did the first approach where they debulked the tumor. and then all the edema, lo and behold, all the edema went away, and they never actually had to do a second case. Is that right, Eric? So that is a very valid approach where you can just debulk the tumor and just leave the rind of tumor over the brain without actually getting a CSF leak, and therefore the CSF leak actually goes dramatically down. However, my approach for this case, if you go back, Gabe, can you go back to the imaging all the way back? So this is actually a little bit further back, and I don't know if this is like very anterior planum. So actually, I wouldn't bet my money actually that this person actually doesn't have olfaction. Also, it seems that it's involving mostly like the left side, so it's possible that the right olfactory tract is actually fine. The other, right? So I think it's probably
82.
okay. All right. So another couple of things.
82-year-old with this?
They don't
can't
see,
smell a thing.
they don't
Come on.
hear, they don't smell.
And he had
okay?
COVID too. Come on.
Right. Okay. The other part is that another key thing that at least I look a lot when I'm trying to decide approach is actually the supraorbital ethmoids. So if you look at this area here, there's people that have very pronounced supraorbital ethmoids, and there's people that have no supraorbital ethmoids. And for this tumor, Gabe, actually it would take the rim. And I think if you do take the rim here and then actually bite down all the supraorbital ethmoids, you can have an approach that essentially like this. That essentially gets into the tumor without retraction much of the frontal lobe. If you bite down all the supraorbital roof down to the first ethmoid. And then I would use a lumbar drain. It takes another 20 minutes. So lumbar drain, 100 mannitol, take the
Lumbar
rim.
drain does that have any more? So we're going down the CSF leak rate. Does that have any morbidity?
Definitely an
Just
82.
putting it in.
Just putting it in.
82-year-old? Yeah, sure.
It depends.
But
Never
you
had a subdural with an 82-year-old.
I'm going to take it out at the end of the case.
Just messing with his CSF at 82. You've never had a subdural?
I've had subdurals when you leave it in, but when you mean like
No back pain, no nerve root injury, no nothing.
you're doubling your risk of meningitis too, essentially, with the lumbar.
I honestly
You
don't.
are. You have two openings into the CSF.
So going back
I
to
think-
Ted's paper talking about 2000 whatever to 12 and then 2012 to 17, I do personally feel like the lumbar drain is traditional.
I think if you put a lumbar drain and leave it in for 4 days or 5 days, I think that's a risk. I think if you put a lumbar drain force, you can even do a lumbar puncture and drain 40 cc's of CSF and then take the needle out. That's all you need.
But you would do a cranie or an EEA on this? Which one?
I would do an eyebrow incision,
Yeah.
but with essentially with taking the orbital bar and then bite down the orbit roof all the way medial to the tumor.
Nice.
That's what I would do.
Quick question just for me. Are you guys opening the dura subfrontal or are you opening it superficial? And then going intra-axial?
Over the tumor first, bulk it, and then actually.
So you would go subfrontal and then.
So here.
So that's
retractor.
another Mike Coyne thing that he wrote about. So I have to say that the transfrontal sinus approach, there was no brain retraction whatsoever.
Yeah.
It's like right there. That's the advantage. Now, as I said, Dr. Chacon and I are both debating this. There are actually two elements I'd like to ask the audience. One is, well, let's talk about the bone work first. Does anybody think that going through the frontal sinus is insane?
But I think it's unnecessary.
You think it's unnecessary?
here we
Now,
go.
I have to tell you,
I wanna hear
I have to tell you that again.
It's a yes
Again,
or no question.
another Floridian has told both of us that we're doing neurosurgery in the 1980s. So you're not the first person to criticize this. Go.
No, but
go.
No, I think this is the battery. This is not the microphone, is that?
This is the microphone. It's recorded.
Oh, okay, perfect. No, but we used to take the frontal sinus in everybody, and then really when you talk to the rhinologist, they tell you that it's actually a mess because we spend about maybe like 15, 20 minutes cranializing the frontal sinus, but you should really spend like a couple of hours to really dig out every single piece of mucosa to make sure it doesn't get.
82.
Well, but they get but if you occlude the frontal sinus tract, frontal nasal tract, then you're gonna get a mucocele at some point in this patient's life. Now, what I'm also a vascular surgeon, and I would like to to ask all those people that have clipped an ACOM aneurysm via pterional approach, you realize that when you look at the ACOM, if you just shift your scope, you see this olfactory bulb all the way to the cribriform plate without really retracting any frontal lobe, simply because you open the Sylvian fissure. Now, I'm very sensitive to what you said about the timing of the surgery. And I think that the difference between an LSO and a mini pterional in terms of location is not that much different, because it's just a question of where you put the incision. But I think that the mini pterional allows you, first of all, to completely avoid the frontal sinus. And then because you are able to open the Sylvian fissure, the frontal lobe, and I will go from the side where the edema is, it falls really away. And then you can reach this tumor from the back. And again, next time you clip an ACOM, you pay attention to the fact that you can see between those orbits and in the foveate moedalis without really doing any effort. So I have to admit that for this type of cases, which I used to do all by bifrontal and cranialize the frontal sinus to be very flush and then put the pericranial flap and all these kind of good things that I think on short term they're very good, but the long term morbidity of the frontal sinus is necessary.
You're advocating a
MPT
MPT rather than LSO.
Why a fissure split on this patient though? If you're going, it's a subfrontal lesion.
To
Why
get
do you need
relaxed. To get
relaxation of the frontal lobe?
Because once you open the Sylvian fissure and the optic carotid system, you get a bunch of CSF drainage, which prevents you from having to put the lumbar drain, which again, I think
That's
wastes
a
time.
lot for this guy.
And then the frontal lobe just falls back. So that's the only reason why you open the Sylvian. You don't have to open all of the Sylvian fissure, but the proximal part.
But you can do that with an eyebrow too.
Yeah.
You can
And
open
LSO.
the, yeah, absolutely.
But
You
I
can
think the problem with the eyebrow and the LSO is that in the end, your real trajectory, the best you can do is really like this. And so this part is always a little bit harder to get because it's so superficial. You know, if you get there, you can get to this part very well. Yeah. But this part is always a little trickier than you use the endoscope or whatever you want to use.
This is a shallow sinus, though. You're seeing the sinus, but on the sagittal, it doesn't go very high either.
So this is a very important point for the trainees and especially for maybe the recording audience, is that you go transcranial. Well, transcranial is not just one thing. Transcranial could be 100 things. And even minimally invasive transcranial, an LSO versus an MPT, as little as maybe a centimeter difference, it's a different operation. Right, so the trajectory is different. So an LSO and an MPT are different things. So I got one vote that the frontal sinus is insane. By the way, Jacques is completely in your camp, saying that we're operating like we're 1980s. But the next question, follow-up question. Does anybody think that the open gull the open sky gull wing incision is insane? That you would go this way?
I really like this idea of coming from the front like you did, but I think in my mind just a bicoronal with the same approach coming from the front. I love Aversa. Toninho does this a lot. I just had a couple patients that had this incision elsewhere and it doesn't look good. I was not, at least I don't know if they didn't do proper. I had never done myself, but what I've seen other patients with it, they were not happy with
You
the.
also use a plastic surgeon.
If I would go from the front here, I would go with the bicoronal.
So Mike Tricorian is writing about it and going and telling me that I'm the same doing this thing. And,
Yeah, I agree with my Chacon.
Danny, what would you do for this?
yeah, okay.
Yeah, so first of all, I really want to congratulate you for picking and the way you exposed this case because when I heard both, I agree with both analysis of coming endonasal and open with the right side, and I was thinking, why? You got precise at the moment where becomes art, which one you're gonna pick, and I was thinking in real life, I would be sitting with this family, with this patient, and thinking, is this person really sick, or I can go endonasal? Because I agree with Madsen that endonasal is a more complete surgery. That's what I would do if the patient was a little younger and healthier, because I can get the hyperostosis, I can get this whole tumor out, particularly if the smell is gone. If the smell is there, I would definitely do a craniotomy. My tendency is to go away from the edema, so there's a right side beautiful access there, and my tendency is to go eyebrow much faster. I would do like what Zada said. So if I felt that the question here is that AFib really enough to say, let's do a little less in terms of resection and put this, so this is the art. So that's why I'm saying I will be looking at this patient like, this patient tolerate a full endonasal, risk of CSF leak, or no, you know what, let's just give up, then I would do an eyebrow right side, and it's difficult, like the eyebrow to get anteriorly there, sometimes it's not easy, but this can be resected with an eyebrow. The only problem will be the hyperostosis. You see the enhancement on the bone that you see that in sagittal. That part you will not be doing a complete resection with the eyebrow, but this patient doesn't need.
Exactly.
So I agree with you, but I would always kind of be hesitating, like I can do a better resection endonasal with this, and then medicine is right. So it is the moment of art. That's why you pick the perfect case.
George, if the patient has smell, would you go from the
Craniotomy. I would do a right frontal. I would do right. I go away from the edema. That's yeah. If I do left for whatever reason, then I will remove the rim, like you said. But in this case, if it was bilateral edema,
where do you think you have the highest chance of preserving?
so then I see if it's asymmetric. I agree with you. But this looks symmetrical. Like if you look at that corona, it looks like in both olfactory grooves. Like if it was in only one olfactory groove, I would go the side of the edema to preserve the smell on the other side.
Do you think olfaction's such a big deal, like number one in this guy? I mean, that's like number 4 priority for me in this guy.
Man, I had a 78. Let me tell you this story very quickly here, like you're telling stories. Gabi, listen to this. Listen to this. 78 is not 82, but 78-year-old, a former professor of the university, came to me with a little bigger tumor, but the tumor was just in the left olfactory groove. I did a modified OSEA, removed the bar. I told him I'm not going to do endonasal because the risk of the smell is normal. He loved his wine. I took the whole tumor out through a craniotomy, coming through the left side, taking the bar, preserve his smell, and he became one of the best donor of our research program. Right? So smell is important.
I do want to state that transcranial route doesn't bet that they have smell.
Yeah, hey, that's very true.
In
On a
fact, 50%.
midline tumor, even if you're taking that, the chances are.
Dr. Sorensen.
Okay, I agree.
So this is definitely not a sexy reply, and I'll probably be kicked out of the North American Skull Base Society because there's no skull base codes for it. But I've done a few of them this way. I've done it all these other ways before, but I do think there's a role for the interhemispheric approach, transfalcine, and I just did one last week, and I've done one recently. When you go from the opposite side of the DMA, he's 82, that right frontal lobe, no problem retracting that. Give him some mannitol. I roll up cottonoids and stick them on either side. That's like just soft retraction. Cut the falx. It almost always just comes out of that edematous frontal lobe, no problem. Really, you don't really have to hardly do any work at all. The side on the right, no problem. You can get to the deep part in the valley, no problem. You just go above the frontal sinus, that little tiny frontal sinus. So you're still low because that frontal sinus is tiny. Just above that, so you don't have to deal with that. You don't have a CSF leak risk. You're going to get away with retracting that frontal lobe just a little bit on the right. It's not edematous. So I'll turn in my NSBS card now.
Yeah.
So I think
I gotta just come to Paulo Aguiar is a neurosurgeon from Brazil. He has done a lot of this, exactly like you said. And I just saw a video just a few months ago, and I never thought about that approach until I saw that video, and it's very impressive. You did exactly like you did. You said I got the brain nice and relaxed, is able to see both optic nerves, even if the tumor goes more posterior, able to roll it off. From posterior, like I was in Germany, he was showing his work in Germany. I was very impressed. So I just want to mention that there's a space for that.
Yeah.
so. If you're one of the attendees of this conference, I should get in the camera view. If you're one of the attendees of this conference or watching this later on, I think you get a sense that there's really no right answer or wrong answer, right? And to your point about, getting the right answer in the hot seat, there is no right answer. Controversial, when you sign the consent, there's no controversial. So at the end of the day, I don't remember who said it, but what you're comfortable with, what you've trained the most in, what you spend the most hours in, what you talk to the patients about, that is the right answer. And at the end of the day, you just, patients do well, tumors out, the goal of surgery is done. That's it. That's it.
Excellent.
Nice.
I want to say something like every option that was given is in the armamentarium that we're just lines. But even every point that was made today still made me think that the workhorse of the Terion is still useful, because every counterpoint, for example, you want brain relaxation, the Terion can give you that, open the feature, that's in the brain. You want to go to a lesser area that is less inflamed or less invaded, you go to the right side. You still use the Terion, it's to fight with a lot of brain tissue to retract, and the goal is to go to the right side to avoid more brain injury to a less dominant side. So I think every counterpoint is good and it's for my learning, I appreciate it. But I think at this stage, looking at all the facts that were taken today, I'm still choose the Terion for this case.
I would have one last comment about that, though. I don't think there's anything unusual about that, and especially at the start of someone's career, I think that's a very reasonable thing to do. But you should critically assess after every single operation how much of the exposure was unneeded. And then with your career maturing, it becomes small and small and small. You notice that the older surgeons here are saying LSO, MPT, very subtly different. You don't need the whole Terion as the whole, as classically described. So start with that, but go smaller as you feel comfortable as you mature. Dr. Zada, final words.
On your boards, on your oral boards, if you say Teriono, you will be fine all day long for this case.
Right.
All right. A round of applause for Walter Jr. Thank you very much for attending, and Gabriel.
Real quick.